Rebecca. Being with you. Um, Hello, everybody. Today, another fun day with a really special guest, and a dear friend of Sonia's and mine for many years now. We'll cut to Rebecca Adelman in a moment here, but just to say some quick housekeeping things, and I'll try to keep it quick. New folks, this is just a safe place. We will, Rebecca and I will go through some material content, as they say, and level set, just share some sort of general basics in the subject matter of the day, and then we'll cut to questions. And before we go to the mechanics of that, I just want to say this is a safe space. Anything goes here within the bounds of kindness and respect. Feel free to say or ask most anything within that kind of context, and or just sit in silence. That's fine too. Zero pressure here. It's meant to be a safe place to ask and hear and be heard. Okay, over to you, Sones.
Thank you. Hi, everyone. Thanks for being with us. So as BJ mentioned, he and Rebecca are going to go through some topics. And then the best part is we get to chat with you. So there's two ways you can do that. You can click the raise hand button and we'll unmute you and you can chat with BJ and Rebecca. And if you'd prefer to not do that, you can click on the Q&A, type your question in, and I will read it out loud for you. So two options. And the chat is open as well if you want to throw anything in there. Thanks so much for being with us.
Thank you, Sones. And as ever, thank you, Sones, for all the back work on getting this together. We love you. And I know I'm speaking for you too, Rebecca, here. So, okay, I will say, let's let you speak for yourself here, but I will just say it's extra fun having Rebecca with us. We've known each other for years. Rebecca is an attorney of all things who's worked in the I will let Rebecca say these things because I'll butcher it. But in her work as an attorney and as a caregiver, my little sweatshirt, we've gotten to know each other over the years and shared all sorts of fun things. And we've done some work together on something called Guide Path, which maybe we'll talk about today, perhaps. We'll see. But anyway, there's just a lot of shared interest, and it's fun for us, besides just loving each other as people. It's fun for us to mix our disciplines. So the law and palliative care clinicians and things, may not be obvious bedfellows, but in this case, there certainly are. There's a lot of shared work and shared spirit that we get to together. So anyway, Rebecca, thank you for being here. It's a real pleasure to have you.
Thanks. I'll just say it myself because it's so true. I love you both very much, and I am ever grateful for the work that you do and continue to do. And there's so much intersection in everything that we do, particularly when it comes to the sort of the emotional value of transitions in care and things that we're going to be talking about today on all things facilities. Just to, I guess, give myself a little bit of credibility for being on the show. My name's Rebecca Adelman. You are in my office. It is just an extraordinary day in Memphis, Tennessee. And I am an attorney, been an attorney for, I don't know, 30 plus years, and spend the bulk of my time advocating for, defending, showing up in the healthcare space for senior living. And that's what we're going to talk about today. So I'm really excited about that. And we're going to talk about all things facilities. BJ, do you want to get us, get us sort of kicked off?
Yeah. So I just want to pick up on something you just said ago. I mean, today the fair amount of the content might we're talking about places and sort of some of the logistics of where care gets meted out, and some distinctions between these licensee designations. And on some level, that may sound a little dry, but it's really important. As any of you know, if you're looking for care for yourself or someone else, it's very tricky out there, and where to go for which piece of the puzzle, et cetera. So yes, we're going to be talking about some sort of logistical and clerical things on some level, but underneath that, just underneath the surface, is a very generally pretty emotionally laden work. These are places where we spend out our days, or people we love spend out our days, and the care and the things that happen under these roofs, powerful and profound, and it can go many ways. So to Rebecca's point there, all emotion welcome here. This, what we talk about might bring up all sorts of memories for folks, and that's all welcome. So with that, I'll just simply say, Rebecca, to our first slide here, uh, as a palliative care person, back when I did a lot more clinical work, it's very obvious to note, anyone in healthcare for 5 minutes will know how the transitions of care, that is moving from one setting to another, or moving from one modality or mode of care. For example, sort of curative care to hospice is a big transition, and sort of spirit and philosophy and what gets meted out. Similarly, moving from a hospital to a nursing home or to assisted living, et cetera, huge moment. And this is where healthcare generally doesn't do a great job. Those transitions can be cracks, and a lot of things and a lot of people fall into those cracks. And one way to kind of get at healthcare, try to repair healthcare would be, if we would be strategic about it, is go right to where the care transitions are happening, because those are the vulnerable moments. So
Yeah, I think that's right. And I think too, when we talk about transitions of care, I always like to remind myself that it's not just sites of care. It's like also transitions between care providers. So, it could be your doctor to your nurse. It could be your nurse to your care provider, your frontline caregiver. And so I think those transitions are critically important. And when it comes to, and we'll discuss this later, but when it comes to like empowering ourselves or having some kind of support like you guys offer here, so just in your work but also in these webinars and in all your resources, like empowering and raising awareness around sort of not just what to ask, but really how to find the right questions at each transitions of care, and how to really explore how we feel about the transition of care. And you have here planned or unplanned. Planned or unplanned transitions of care, have their own unique challenges. And so you mentioned, moving from home to, normally what we see is, or normally what we experience. And then I think this is kind of a nice segue into the specifics of levels of care. But, normally what we experience is there's this sort of decline in our lives. And, I want to stop one point and rewind for 1 second.
Yeah, please.
I think also in my experiences in all the years I've been, working in senior living, seniors housing, with everyone in the ecosystem, a lot of times this whole conversation has a sort of a negative vibe to it. Like, oh, I gotta, this is really all about like significant changes in my life and my loved one's life. And we've got to make these very intense. This is all very true. But I also want to, I guess, start our conversation here today on like a really uplifting note and on a really positive note that, living together communally, moving together as we like age and we decide we want to age in either our own places or age in other places is really like an opportunity for us to be in community. And I want to, there are a lot of studies out there that talk about like extending our lives and the quality of our lives by being together. And I guess I just want to frame this also around, because it can be really heavy, talking about like, I'm going to go to assisted living, or here's the level of care and everybody's health is deteriorating. But I want to just frame this for you and me, BJ, and everyone else. And like, we're just keep living. This is really about just continuing to keep living. And we have to go through this all together. And how can we make these transitions and really understand this new care setting and how to be co-partners with everyone new or meeting in the setting. So I felt like that was important. So we could infuse some like, I always like to start a meeting with a positive focus. So that would be my positive focus. How about that?
That's beautiful, Rebecca. Thank you. And between us, I think we'll cover the emotional gamut. I think it's really important what you're saying is, I think our language, the word that came up a moment ago, decline. These are places when we're in decline, we have to go to this place, or even worse, we are put in a place, like we're a piece of baggage is some of the language around this. Like, did you put mom in a home or what? Like it implies, and the general vibe around these places is not necessarily a happy one. But I think that statement is uninformed. Under these roofs, all sorts of amazing things happen too. And the reason to go to any of these places is because there's more support waiting for you.
Mhm.
You and I might have a lot of critique for the system and know
Mm-hmm.
that it could be pushed to be better
Mhm.
as a system per se, but let's not lose sight of what's happening under these roofs, and the fact that they exist at all is beautiful. Is to serve people, to be together, et cetera, et cetera. So
Yeah, and you're wearing your awesome caregiver shirt. Let's not forget that it's about that too. You like in a sense, today's conversation really is about that. It's
yeah,
about caregiving, us caring for ourselves, us caring for the people we love, the caregivers who are in the communities where we're going to be transitioning. So I think that's, that's just kind of shifting our paradigm around that, I think is really important. And as we continue to encounter an aging population that's growing and growing and growing, whether that's healthy aging, whether that's not healthy aging, whatever it might be, the more we can show up to be having these kinds of conversations, particularly where the palliative care world and the is involved, and having these conversations about, man, you're still living until you're not living. I mean, in the end, right?
yes.
And
Amen.
so how do we understand that, I think is the sort of the heart of our conversation. And I think what we see, like kind of shifting a little bit to nuts and bolts, and then maybe we can kind of zoom in nuts and bolts and then zoom
Yeah.
out,
Yes.
is, normally what happens, just for purposes of our conversation today, generalizing, is there's either a sort of a decline in health due to a multitude of underlying conditions. We just get old sometimes it's not, but we're going to focus sort of on the older adult population.
Mhm.
And we start to break down a little bit. The machine gets needs a little oil, and things happen, and we have underlying chronic conditions. This is just the reality of life.
Right.
And so then at some point we may need, for either reasons of safety, or it could be like a whole family ecosystem just can't meet the needs of someone they love. We have to make some choices, and we hope it can be planned, because then when we have opportunities to sort of plan transitions in care and going to live in a new place, I think it creates less emotional stress, less financial stress, less family stress, etc.
Yeah.
So physical stress. But sometimes we also have this acute event happens. There could be a fall, there could just be, some exacerbation, there could be something happens, and we wind up in acute care setting. We're just being cared for in the hospital. And
Mhm.
from there, choices need to be made about, again, typically we're looking at, well-being, and we're looking at quality of life. And so many in this ecosystem are focused on safety. And I want to also focus on safety, but I really think
Yeah.
yes, it's important, but I really still want to talk about, quality of life. Where can I get a better quality of life for my loved one if I can't provide it, or they can't provide it for themselves? Where can they still not, feel like they're socializing? And where can they feel like this sort of heart of value? And I think, and of course, be safe, but
Yeah.
safety can't be the only.
No, that's such an important note. I mean, maybe we can talk about that throughout. Safety, I mean, right, who doesn't want safety is a good thing. But like any one variable, if the fidelity is just to safety, well, then we're gonna all be wrapped in bubble wrap, not be allowed to get out of our beds, and
Door
not
locked.
exactly. And so there's a balance to be struck, and each of the facilities will mention how it might have different sort of measures around safety for good reason. But it's also worth noting, to your point, that nursing homes, post-acute care facilities, all these places, yeah, there's some hard places out there, and it's a tough model, but there's a lot of good people trying to make these models work. And a lot of people concerned about safety for very good reason. But I think what you're pointing to, what we want to kind of open up, is there's more to life than just being safe. Just like
Yeah.
there's more to life than being comfortable. So as a variable, safety is very important, but as the holy grail, it can lend us to a life unlived, if not careful.
And, you know, and to that point too, I think it's important when we're going to be talking, I guess, soon here about assisted living, and then we're going to talk about memory care, and then we're going to talk about skilled nursing care. And this is a nice little transition, a little transition graphic I wanted to share. But I also think it's important for the families to understand that they don't need to be like only focused on safety. What's safe for mom? It's
Yeah.
like, well, where might mom or dad be more autonomous? Where can they still have their autonomy and their freedom? And so
Yeah.
having like a broader conversation about it, so we don't get too tied into guilt, or we don't get too dug in any one place. And I think that's important to be able to understand that, like here in the graphic, right? So you're at the hospital, you may have to go to post-acute care, you know, and I think the important thing about this is we all will go through multiple transitions in care sites and multiple transitions between care providers throughout our whole older adult life. It's not like one and then we stop, and, you know, we might go back and forth. And so navigating that and sort of having the skills to, like, you know, really move between these worlds is so, and the support to do that. So here, kind of just illustrative of my point is, you know, you're typically like, let's say we're in a hospital, then there may need to be a decision to go to a rehabilitation facility. Maybe it's a cardiac rehabilitation or some kind of rehab facility, or maybe you're going to go back home. And then after you go back home, you realize that there are more care needs, everyone's emotional and physical needs. And so you go back to maybe a long-term care community, which could be assisted living or memory care, or, and then, you know, BJ, this is where, you know, your world is too, is this sort of movement through and around hospice and palliative care. So this is just like a nice graphic to recognize it's not linear in any way. It's linear in terms of movement, but it's circular in terms of, you know, of us all moving as a whole ecosystem together.
Right on. And it's not a one-way street. Even hospice, which is generally a, you know, end stage landing place, as we know, a not insignificant number of people actually graduate hospice for whatever reason. The illness quiets down and there's some new treatment on it, whatever it is. So just to your point, this is not linear, and it's not a one unidirectional. So you can spend time in any one of these places, go home, so anyway, I'm just repeating what you said. But important on this graphic here, we're going to go through some of the specific places, because there's different details per place. But just for the audience here, where in this graphic does say like a nursing home? And there's a phrase that a lot of people know. What's
that's
a nursing
great. That's great. So here we're looking at nursing homes under long-term care. We'll put that under the umbrella of long-term care. You're going somewhere for a longer term. We know we go to assisted living and we go to memory care and we go to, you know, when we decide to transition and live in a skilled facility in a nursing home, it really is for long-term. And I guess that's the whole point. You're going to a new home, you know, and that's, I think, important for us to remember. This isn't, you know, going to you know, a long-term hospital. I mean, this is your home, and people live in your home with you, you know?
Yeah, it's an important note and a little distinction from the letter of the law on the slide here. In a way, to your point, home as a place for our bodies and our spirits or to land can be, as we know, just about, it's almost a state of mind too. So one can be at home. I lived in a hospital for many months as a patient. That became home. You know, any of these places can become home. And in some ways, that's a good goal for all of us as families to imagine as we go into these places, or someone we care about going to these places, is a good goal. To your point about keeping an eye for where things can be even, you know, more wonderful, not just less shitty is a phrase we use. Like, you know, a good design cue is, how can you make this new place feel like home? Whether that's
and how can, and I think to that point too, is that, you know, when we're moving to a new home, you know, we're moving to a new home community. So how do we create a family? So it's not, you know, again, you know, I'm in litigation, so well, I'm all over the risk spectrum, but when I'm in litigation, it really is polarized. It's us and them. There was a health harm, you know, and the idea of, you know, there was a home in there is nowhere. So I think that the real objective when we're making these challenging decisions is to we're making these challenging decisions is to really be considering, like, how are we all partnering together? That's it. And how are we creating a new family in our new home? And I think that's having that frame of mind, I think, really gets us off in a place that starts to dissolve some of those underlying very difficult emotions.
Right.
And stresses and guilts and worries and families, being in conflict. If we can start to dissolve all of that early on in these transitions, man, it's like it's already a win in your new home.
Yep. Amen. Well, let's move into some more specifics here.
Oh, I love this.
Yeah. Did you find this picture or did Sonia find this
This
picture?
is all Sonia's work, and Sonia, bless you for, I'm loving this. That's going to be me. I'm going to be the cheerleader up at the front, man. I'm going to be at the I'll be at the top of the pyramid. I love it. So I'll sort of just dive into it a little bit. When we talk about senior living, again, I think this is the larger umbrella, we're aging, we're trying to get into a new home and a new community where there are different levels of care. We need more care than we can get at home. Now, keep in mind, this is beyond the scope of our conversation to discuss home health and ways to stay in your home. That is an option, and it's a really great option. But for those who aren't going to stay in their home, senior living is really sort of the overarching, I guess, descriptor of what's next, and under senior living, we're going to come to, we're going to discuss, what it is, what is a different level of care for assisted living, what are the different care levels, and who pays for it, what is the payer source, which is often driving the financial stresses. And then, what is the level of care? So again, I think we're going to cover each of these for each different sort of transition.
So by itself as a phrase, senior living doesn't necessarily imply level of need per se. So it's just the big umbrella, as you're saying.
Yeah. And I would think that it doesn't include, and someone might have this question about, well, what does independent living mean? Or what is a continuing care retirement community? Or what's a life plan community? Again, a little beyond the scope of our conversation. We're trying to just kind of keep it at a 201 class. But, there are whole communities where you can go and independently live, and then you transition in care in that whole campus, in that whole community. So those are life plan communities. It could be continuing care. So that all falls under senior living.
Gotcha.
Yeah.
And one last question here. Senior living in this country generally implies 65 or older. Is this a Medicare nod, or or really for folks who might be younger and have lots of needs? Or
great question. That's a great question. I think it's probably 60s and older. Yeah. You know what I mean? 65 is definitely the Medicare cutoff for it. But I think it's, when you see it kind of thing. Mm-hmm. Some of us, may need to want to transition to a senior living community, not because, we're 65 or 70. Maybe you just don't want our zero lot line anymore. And we just want to go live with other people, and we need a little bit of help, and we don't want to be isolated. So lots of different definitions. It's a great question, though. I don't have a specific answer to that. There probably is some kind of a data-driven answer to that I don't have.
Well, let's see. I mean, so like all the language around healthcare, the words kind of mean slightly different things, different places. So it's pretty loosey-goosey.
I think it is.
I get you those overarching umbrella. That's the that's the language we generally use.
Yeah.
Probably a whole other whole other webinar on what it's like to be a younger person who, living in such a place for whatever reason. There are folks, we're going to keep our comments pretty general, but there are outliers and exceptions and all sorts of things. So
mental health, behavioral health, much younger adults, homelessness. There's all sorts of a lot going on there that we should pack that into another day, though, because it's really important, particularly when it comes to palliative care.
Right on.
Yeah.
Okay. Well, for now, for our 2.0, our 201 class, let's keep moving. So let's get down a
Yeah.
little bit more in the weeds. So assisted living, a phrase probably most of us have heard.
Yeah.
What is it?
I'm going to give you the really easy version of this, and then so we have plenty of time for people, hopefully, to ask some questions of us. So really, assisted living are for older adults who need some assistance with their activities of daily living. Okay. I wrote down here in terms of my notes, they need some, maybe a little bit of medical attention from an outside doctor. They go to their doctor, or their doctor might come to them, but they just need some help with their activities of daily living, maybe bathing, maybe dressing, maybe medication administration. And it just is a sort of a more home-like environment for someone who needs extra support. I do want to bring this up because this came up in our preparing. So, I've been in senior living for a lot of years, and 20 years ago, somebody in assisted living, a person who was called assisted living their home, BJ, really had the sort of the medical and social sort of, let's just call it demographic or profile of somebody who really now is in independent living. Assisted living now, which is a little bit different, and I think this is important for everyone to know, assisted living now, and again, it's regulated by the state. So this is again, a state by state. If you're in your state and you are making choices around assisted living, make sure you understand what's going on in your state, what they call things. They may call things a residential care facility. They may call things assisted living 1, assisted living level 2, assisted living level 3. Just make sure you go to your proper regulatory group and your healthcare groups in your states and really get to understand what's happening. But, assisted living now looks a little different than it did 10 or 15 years ago. 10 or 15 years ago, or now in compared to 10 or 15 years ago, we have, people who live with us and call assisted living their home, who are on multiple medications, who have a lot of underlying chronic medical conditions, where like 10 years ago, they would have actually been in skilled nursing care. So everything has really shifted.
Yeah.
Which is where palliative care and hospice care are coming in. So that's why we've got the new rules around the HOPE audits and the hospice audits and the palliative care audits now in skilled facilities that CMS is recognizing, sort of the advanced, the sort of the advanced chronic conditions in senior living. So, but in assisted living, generally it's, you need some more assistance. You live in an apartment, you got to lock on your door if you want it. I mean, it's just your new home.
It's a little bit more like an apartment than it is like
It is. It's apartment living, typically shared dining, shared socializing. You can still drive your car around if you want. You'll get a parking spot. You can still do whatever. It's just really about getting a little more assistance, and a lot of times really for people who really want more community. And I think that's really important. It's a very social model, assisted living. And it was designed that way as a social model. And who pays for it? Assisted living is, under most instances, it's a private pay. So you are paying out of your pocket, your loved one, your family member, whoever is, going to pay for a monthly rent and some additional assisted living support will be private pay unless you have long-term care insurance. So long-term care insurance, not Medicare, Medicaid, but your own private long-term care insurance will also there's certain criteria, but will also pay for assisted living. So I think that's important to remember when you're deciding, or making choices about, should I get assisted living? Should I get long-term care insurance or not? The cost of living longer is greater. And it's something to consider. I'm not a financial expert, but I know that for a fact.
It gets expensive. These places are expensive.
Yeah. And Medicaid, there are some Medicaid waivers that can assist with some costs, but it's either going to be your private insurance or it's going to be primarily paid out of pocket by by you or someone who's helping you. So important to remember. So, and there are different levels of care. Like I said, this really it's state driven in terms of the regulations. Some assisted living communities won't take anyone who have, certain types of conditions, But then there are obviously some safety features, you need to be able to evacuate a building in X amount of time if there's a fire, kind of thing. So again, very regulated.
And one note on that, Rebecca, like I just want to interject real quick. I think, of course, in terms of drilling down, so for anyone in the audience who might wonder if assisted living is for them or someone they're caring for, as you're saying, place by place, it might differ a little bit, state by state, it might differ a little bit. So I guess the advice would be calling, if you know of a place or two or three in your neighborhood, calling them and having an informational interview to see how that works, what they cover, what their eligibility criteria are, et cetera. And then also, if you have a sort of a healthcare team, most of us living with
100%.
chronic illness will have a team, and somewhere in that team is often a social worker who's tends to be a go-to person who has their eye on these kinds of places, among many other things. So in terms of where to get counsel and what feels right, besides calling these places directly, I would point you to especially social workers on your clinical team or discharge planners in a
Just
hospital.
a great point. And also go and I will say that in most states have really robust resources for this population. They just do. So your healthcare associations, AARP, I mean, there's all sorts of resources out there. So just go nose around and you'll get a lot of support. So
Okay.
skilled nursing.
So this would be the next, so this is sort of the next level up, essentially, needing more medical support.
Yeah, question real quick. Did we, just to remind me of the order, is memory care next?
Good question. I don't remember.
I don't think we did a memory care one, so maybe we'll
Oh.
just have to call it out.
Yeah,
Sorry about
I'm gonna call it out.
Great.
So for memory care, most assisted living communities, for people who also have individuals with Alzheimer's, individuals who are living with dementia or other cognitive impairments, assisted living also have specialized forms of areas in their community that are designed, and we call them memory care. They call them different things, but for ease today, we'll call them memory care. And the need for memory care, it's usually a more secure area, and this secure area also focuses on sort of cognitive engagement and more supervision for those. My dad was in a memory care area of our assisted living, and so they're designed a little bit different. And so it's important for those of you who are making and helping their loved one make decisions who are suffering from or who have Alzheimer's or who have dementia to really explore memory care. But it's a very specialized area. Again, it's governed by whatever the state regulations are. And, there's typically a lot of therapeutic activities that promote mental stimulation. And, so this particular transition has been is very emotional for families in a lot of different ways. More emotional than transitioning to a new assisted living home, transitioning with somebody who you are caring for who has dementia is just kind of carries with it a different set of luggage. And so I did want to bring that up because cognitive decline for the people that we love, and this better than anyone, BJ, and your team of folks, really does intensify feelings of loss and grief and all those things. So maybe you could spend a moment, talk to us about that, because I think that's an important part of this conversation.
Yeah, no, I think not all chronic illnesses are created equal. The experience, while we might share a common resting place in the form of death or mortality, how we get there, the experience can differ pretty wildly depending on all sorts of variables, including what is the illness or what is the thing physiologically that's bringing about our death. And dementia, the suite of sort of neurocognitive decline illnesses, to your point, Rebecca, come with a particular kind of experience for the person in that body and the person loving that, and the people loving that person. to your point, it's not just memory. We talk about losing short-term memory, et cetera. At some point, the mind starts coming apart in other ways too. And so people can lose their personality, or let's say their personality can shift. And so it can be especially difficult for loved ones because the person that they knew is in some ways not there. And in some ways, there's a new person there, and it can go on for many, many years. So while it is dementia is a terminal diagnosis, it generally plays out over a long period of time, which has different, has a different sort of suite of fallout for people, for family members, caregivers. It goes on a long time. And we know that caregiving for people who are living with dementia brings its own risks to their own health status, et cetera. So yes, there's each of all these illnesses have different experiences, et cetera, but there is something around dementia, the suite of dementia-related illnesses that comes with a particular challenge. And as anyone knows who's trying to have someone live with them and with that diagnosis, at some point it gets very hard. So to your point about a secure facility, simply meaning like, people will wander. So it's not uncommon for someone with dementia to get up in the middle of the night and not know where they are and just walk out of the house and just walk around the street and who knows what. And it can be terrifying. So to your point about a memory unit being locked or secure, it's for that reason.
Yeah. And we won't dwell on that too much, but I would love to at some point have a discussion around dementia and Alzheimer's and palliative care and all of that. So skilled nursing, I can spend a few minutes on skilled nursing.
Yeah.
So skilled nursing really is it's really sort of this next transition to an even higher level of care that's really medical in nature, more medical in nature. So we're looking about, in terms of the need for skilled care, which could be the need for wound care, the need for underlying illnesses like COPD and diabetes and these kinds of conditions that really need medical attention that can't be cared for can't be monitored and properly assessed in assisted living. So and oftentimes rehabilitation is in a skilled nursing community. I guess I want to bring up too that, normally skilled communities come from a transition of acute unplanned care. That's typically unplanned decision making. So I think, again, transitioning our loved one into a new home in skilled nursing really has a lot of, really kind of carries with it a lot of underlying, we'll leave some time here and talk about these underlying emotional things, but in these different emotional challenges. But this typically you're moving to a skilled nursing community because of an unplanned or unexpected sudden health event. So this is like, the whole family goes into a whole other mode.
Yeah.
Medicare pays for these stays, typically the short-term stays following a qualified hospital stay. Medicare will pay for these stays up to 100 days, and then facilities often there's like co-pays, and it's a whole regulatory Medicare, Medicaid, insurance-related payments when you get to skilled nursing. Out-of-pocket expenses, sometimes if they exceed the Medicare beneficiary, the benefits of Medicare. Again, this is just sort of exploring the Medicare benefits with the person. They have whole divisions in your state. You can sit down and talk to someone, do it early and really understand, what are my loved ones' Medicare benefits? What can I expect? Yet another part of the financial planning is really, we'll seek to try and dissolve some of the stresses around that. The earlier we can start planning and understanding, all these different parts of the ecosystem. So long-term care insurance may or may not pay for skilled. So that's kind of the skilled nursing. Skilled nursing is just what I think people imagine in their minds when they say, oh, don't put me in a nursing home. And I really want to try and, again, sort of part of my life's mission is to change that whole perspective and to understand that skilled nursing is just yet another transition in our life story. And, it's not like the old boarding houses of, 1930s. these are people who are caregiving and people who have a lot of skills around being able to help manage your loved one so their quality of life can be maintained, so they can retain some level of independence and autonomy, even though their machine, is starting to decline faster than someone else's, so it's important to remember that.
Yeah, to that point, I think remembering in the abstract is sitting here, like I'm whatever, 53, I'm sitting in my home, I can move around, I can do whatever, that's great. There will come a time in my life, right now, the idea of a nursing home sounds, frankly, not great. It would be a big loss for me to move from this life to that life. But that's not the frame. The frame, when you actually need a nursing home, it may feel like a real godsend because the frame of reference, the relativism here is not, oh, living freely, walking around, doing everything you want. It's because home or wherever else got so difficult. So these places in the abstract can sound like not a place you'd want to be, but in real time, when your options are few, it can be a godsend. So I just want to kind of call out this
Great point.
relativism with these things.
Yeah, that's a great point. So yeah, and I think my last sort of points on all this when it comes to, and then I'll turn it back over to you, BJ, is that, in my world, sort of if I had to, give someone great advice, a family came to me and said, what are your top three things? My top three things are just your own self-awareness. Like, what are your own underlying feelings and needs about all of these issues? I'm afraid, I feel guilty, I feel, frustrated, I'm concerned, I'm worried. Understanding those first so they can drive conversations moving along transitions. The second would be take time to really understand and connect with the person you love and what they want, what they need, how they want to live their life, what matters to them, what their values are, all of that. And then third would be, consider these people who are going to be taking care of your loved ones as your partners. They are your partners in care. And, let's, they're your new family members. Get to know them. Share about yourself. You're the expert about your loved one's care, so share that with them. And I think those would be my top three, sort of more intrinsic kind of advice, if you will.
No, I love that point. It's again, getting out of the sort of mechanisms of these things. These are at base, these are places that facilitate and house human connection and human relationships. And if you keep that in your line of sight and go tend to those relationships, the experience can be remarkable and certainly better than if not. To your point, get to know your caregivers is a great note, as is let them know you. A lot of things, the concern, the experience of being a patient in any of these places can be dehumanizing, can be sort of, it can feel demoralizing. You're treated like a number, or you're treated like your disease. Yeah, well, to some degree, you can push back on that. Be not your disease. Tell people what you like or what your loved one cares about, et cetera. To your point of going to values, et cetera, and being known, that can really shift the experience. So, all right, my friend, we should move on. And by the way, just languaging, as you said, Rebecca, skilled nursing is often what people colloquially call a nursing home. The other word or sound you might hear on this is SNF, which is a skilled nursing facility. So if you hear people say SNF, that's what they're talking about.
Yeah, fair enough.
So this one we can be real quick on.
This is really, like I was suggesting, in many states, an assisted living community is called a residential care facility for the elderly. So, it's the same, really the same system.
Yeah, gotcha.
Yeah.
Great. We don't need to belabor
But it's
that.
good to know. It's good to know that in each state, it might be called something a little bit different.
Yeah. And here, shameless plug alert, like the languaging around all these things can get a little confusing, more than a little confusing. The book that Sonia and I worked on, A Beginner's Guide to the End, just to note, we took some effort to try to break down the languaging around these things so it's not so opaque and you don't know what the heck's going on. So You might find that book useful on this note. Anyway, I'll just leave it.
Shameless plug. Guide Path is.
Yes, exactly.
It is. It's really, you and I are very much aligned on that. You know, our education and training program around Guide Path, which you and Sonia shared so generously in the palliative care module, is really about that. It's just shifting communication and moving into more empathic leadership around senior living and this sort of, you know, person and family engaged care model.
Beautiful.
Yeah.
And we'll include, guys, the folks out there, Sonia, as ever, we'll include resources,
Yeah.
include notes on Guide Path, and we'll see if we have time to talk more about it. It's really a cool thing you've created there, Rebecca. And quickly,
Well,
you are friggin', I don't know how you work
shit
like
them,
you do,
whatever.
It's really amazing. But anyway, okay. For now, moving on.
We talked about this.
Yes, I think we've got this one.
Yeah.
The point is made. So let's pop out of the slides and get to any questions, comments. You know, these are tips of enormous icebergs. This is not a comprehensive survey. So what's going on? Anybody, any questions or thoughts out there?
Yeah, we got a question that I can read out. In the context of senior living, how does the topic of grief come up when caring for elderly residents? How do families or the seniors themselves typically approach and navigate conversations around this sensitive issue? And what strategies can caregivers use to provide support during these discussions?
Sense, can you read the beginning of that question again? Sorry.
How does the topic of grief come up when caring for elderly residents? I mean, that might be grief of, leaving your home or grief of feeling lonely in a new space. I can imagine there's many moments.
And then Rebecca, I'll kick over to you. I was just going to herald what you just said, Sonia, is first of all, is just the basics of acknowledging that grief is not just when someone dies. Grief comes up in advance of a death, but it really comes up around any loss or even just change. And as we've noted here, even if there's something really good waiting for us at that assisted living place or nursing home, it's still going to take a minute. And even if we're going to call that place home and love it and spend our days there, that doesn't mean there's not some sense of loss of leaving the home or wherever else we were before. So I think one quickish note is what you just said, Sones, is making sure that everyone on the team acknowledges and families are encouraged to experience the grief or to acknowledge the grief that is inherent to so much of this work, and get it out of just the death kind of frame. So it's all over the place is one answer to the question. Rebecca, how would you add to that?
I guess my thoughts on that are really to, again, stay very curious around all of these emotions. So, if you, I think the question, the comment was about, caregiving in a home environment, in a assisted living environment, and being the caregiver or caregiving older adults and how you deal with that. I think it's really about being curious and asking questions, because the caregiver also, one of the things I like to focus on with the folks I work with is, they also suffer loss, are actual caregivers, right? And having some sort of sense of like, it's a bond we share when you come to us. And, and I think that's it, is just to find that common ground, stay very curious, ask questions, and then really education and training around it. I think, we live in a culture that doesn't really like to talk about this stuff. We certainly don't like to talk about, like, really getting old, like, the old, the old no one really wants to take care of and talk about, that kind of old. And I think the more we bring that to the surface and talk about these emotions and normalize this idea of grief, or normalize like getting old and thinking about, I can't drive my car anymore. That's a loss. I can't see my kid as often, or whatever it might be, and just staying curious, and I think that's the way. It's really about connecting.
Yeah, amen. And part and parcel of that is staying faithful to the full array of human experience and emotion, not just trying to stay to the positive side of things, but simply acknowledging the full array of human experience is much the is it's sort of as simple as that in a way. So that can be done in your materials, that can be done in the training of how the staff handles these transitional moments, etc. Anticipates, even when it's great news that now the caregiver gets to rest or whatever else, there's going to be a sense of loss in there too, and mixed feelings on everything. So I think part of it is just simply not crowding out any part of the emotional experience, giving it its due.
It's great.
Yes.
Thank you for that. I'm gonna use that in my work. I appreciate that.
Yeah.
Okay, we got some other questions. What, or are there any goodbye rituals that can be helpful when leaving a home?
Oh, that's a really interesting one. I may leave that to you. I don't know any good, well, I know in my faith. So in my own faith world, we have certain ways we come and we go out of our home, right? And we have a little beautiful mezuzah on the door, and it is a sort of a symbol of the coming and the going, and that we're always sort of, that there's something greater than us out there somewhere. So I would suggest that maybe taking that mezuzah off, or taking something from your home and bringing it with you to your new home, so that you really have yourself grounded in the fact that you are home. And and I think that's really important. And we're working with the team overseas right now in Nigeria, and they're now encouraging folks who are coming to living in their community to bring a picture, to bring something that is a symbol of home. I think that might be, because every threshold's it's a coming and a going. So
Yeah. Well, that's a beautiful answer to your question. I mean, I think I hear us at Mettle here. I think I was often talking about the importance of ritual. And personally, I know I quickly go to a big blank stare in terms of naming any rituals. So as far as my own development, I'm aware that it's extremely important. I think I ritualize a lot of my own behavior. But at some point, I really need to sit down and study what rituals pre-exist us. It's a fascinating world. So in answer to this question, I'll simply say that if you're not sitting on a cultural or faith-based ritual of your own, as Rebecca's sharing, make one up. Just simply noting that these are momentous occasions and big things are happening, and just simply noting it, mentally, physically, or with lighting a candle or incense or whatever else you do. I think there's something about thresholds, which is a great thing to kind of consider as a moment to mark as you move in and out. So I'll flail around to think of any rituals, but I would encourage all of us to ritualize some of this stuff. And to your point, Rebecca, I think a big sort of theme, rituals waiting for us, is bringing, these places are, they're homes when you make it one. When you invest yourself in the place. So bringing a quilt, bringing photographs, bringing important valuables that make it your own, that claim it as a space that you are inhabiting, I think can be thought of in a ritualized way. And I think it's extremely invaluable.
Okay, more questions. What is a good resource for navigating the move to a SNF from assisted living as far as finances, especially for a married couple and only one need of SNF level care? My parents planned ahead and have an irrevocable trust, but I know there are other legal ways to protect assets. Do either of you have?
Yeah, great question. I would really start at Medicare.gov and go there first. And on the Medicare website, you will come up with, there'll be a lot of different resources, and there's probably phone numbers that will lead you almost back to your own state. Irrevocable trust, all the financial planning around, good for you, by the way. The financial planning around, as I'm understanding it, one of your loved ones is needs to go to skill, but the other one does not. So there might be some financial underpinnings there that are a little bit beyond this scope, but I would go to Medicare.gov first and just nose around there and find your way. They'll have a lot of drop-down menus to get you where you need to be.
Great. Okay, we have one hand up. Karen, you may have to unmute yourself. You know the drill.
Hi, BJ, it's Karen Spencer.
Karen.
Hi. So I was trying to help a friend along these lines, and she is dealing with like she brought her mom from out of state to live with her, and she has dementia, and she's kind of rapidly declining. And I already helped my friend get through, like they had an acute hospitalization and they went to a SNF, and they were leaning on my friend, like, you got to get her into a nursing home within 48 hours. And I talked with my friend about goals of care conversations, and we talked about hospice, and she called me back a couple of weeks later. It's like, I got my mom back home and we're on hospice, and I feel really good about this decision. And so I called her actually just this morning. I was kind of checking on her. She's having to cover up the phone as she's talking with her mom, who's like having trouble at the bathroom. Things are at this level, like her mom's forgetting how to get in the car. And my friend had gotten hurt, and hospice recommended that they use respite care. And they put her mom in respite care for like 5 days, and just had a very, very bad experience. Like her mom, she picked up her mom and she was still wearing the same clothes she had been 5 days earlier, this kind of thing. And so I felt so terrible for my friend. She'd already kind of navigated all these things. Her mom is declining, and then she has this terrible experience, and it's just like, well, that's the end of that. Like, no respite, that is not happening again. And I believe there's value in just like showing up and witnessing and hearing the reality of what she's dealing with. But I was like, oh, I don't know what other tools are out there, right? And it seems in line with what you're talking about. So I don't know if you had advice that I could pass along to someone, or like, what else, what do you do in that situation? Are there other respite options? Or I don't know.
Well, first of all, Karen, it's nice to hear your voice. And thank you for speaking up. I think just on the note of respite per se. So real quick, folks. So within the hospice benefit, hospice Medicare, hospice benefit, it proscribes certain levels of care and certain things that are covered, et cetera. And there are 4 tiers within the hospice benefit. One of which is what Karen is pointing to, which is called the respite benefit or respite care. It's theoretically something I love. I love the notion. The respite is for the caregivers, it's really for the family members. So the idea is within the hospice benefit, I think once every 3 months or maybe once every 6 months, hospice will pay for the cost of the patient to go to a facility for 5 days to give the family at home respite. It's a great idea. First of all, it's rarely invoked. And too often when it is invoked, the experience ends up sounding a little bit like what you reported, that it wasn't actually restful at all, just the person trying to get the rest only realized that mom or whoever else wasn't getting great care, et cetera, and it can feel not at all relaxing or restful. So, I mean, one answer or one thought, Karen, is the benefit itself is a good benefit. The notion of respite really makes sense. So wherever your friend is, if there are multiple facilities, and it's usually either an acute care facility or a skilled nursing facility that would qualify to host a person during this respite benefit. So I wonder if your friend talking to the hospice social worker, I wonder if there are other facilities within that community that might have a different experience. So it probably already happened, but talking to the hospice team, getting counsel of which place is better care. The word of mouth notion, for all the ratings and things out there that can be helpful, there's nothing quite like word of mouth. So talking to people in the community who've experienced care in this place versus that place can be invaluable. And often enough, the hospice team, if there's a seasoned provider on the team, will have that kind of detail. So that's one idea. Rebecca, anything pop up for you? And Karen's good question.
It's a great question, Karen, and just, I'm just holding space for your friend and for her mom and for you and everyone out there who is similarly situated. I really believe in the power of, connecting with other people who are similarly situated to your friend. And if your friend can find some other folks in her community who are caring for loved ones at home, that support, just having someone to talk to who is similarly positioned or is going through the same thing, I think itself creates sort of this antidote in some ways to like the frustrations, to not feel like you're so alone and that you're navigating through things by yourself. So
Yeah.
if there's anyone else out there, and I imagine like there's a way to go and do that. I'm not savvy enough to know how, but I mean, I know if it were me that I would go online and I would look, and there's probably like, groups of people out there who, or call an ombudsman, and there might be like a family group, or one of the nursing homes has like a support group, but
Yeah.
some way to get her some support, your friends also some support.
I think that's such a good note, Rebecca, is to, yes, it's about mom in so many ways, and it's about your friend, Karen. So just putting the frame around your friend's experience, what does she need? And as much as that respite experience may not have met her hopes or her goals, your friend's goals for her mom, I mean, it would be worth asking, was her mom okay? Did she get decent enough care? Was she safe? It was not going to be as good as she's getting at home with you in the hospice, but was it good enough? And if so, then okay, then it still might give your friend the respite that she needs. But irrespective of the respite benefit of that 5-day stay, etc., to Rebecca, your point, there's sort of daily self-care here, and finding your way to community around this very difficult time can be invaluable. Your friend taking small little respite moments for her
Yes.
is invaluable.
Yeah.
So it's informal. There's not a program to do so. We kind of have to make it up. But this is where community could becomes so key. And I guess one last point is thank God your friend has you, Karen.
Yeah. Here, Karen.
Oh, that's really sweet. That is so helpful. I'm just so glad I asked. Thank you.
Thank you, Karen. We love you too, girl. All right. Well,
Do
we've
we
done
have
a little here.
time? Do Rebecca and BJ, do you have time for one more
I'm
question?
all good.
Sure.
I
Yeah.
belong to you guys, however long
Yeah.
you need me. I'm here.
Okay. We've got another Rebecca, Rebecca, I'm gonna unmute you, and you may have to unmute you on your end.
Hi, Rebecca.
Hi. Hi, Rebecca. Hey, BJ. Shifting the frame back to that relief care, it strikes me from my experience that when you move someone with dementia into a new environment, it really wreaks havoc with them. And it just struck me that respite care, wouldn't it be cool if respite care provided caregivers to come into the home to stay with the patient rather than having to move the patient to another facility? Because it is so challenging to move someone who is comfortable in their space to a new space, and there's going to be all kinds of negative consequences in many cases of that shift, and then the shift back home. So it's interesting to sort of reframe the concept of respite care. And in terms of cost, I don't know what the difference would be, but it sure makes sense to bring caregivers into the space where the patient is comfortable to give the caregiver respite.
Yes. Amen, Rebecca. I don't know if I was cutting you off, but I could not agree with you more. And like so many things in the sort of the payer world, the reimbursement world, not everything makes a ton of sense. So the cost of being in an acute care facility, or most any facility, probably is much more expensive than what it would cost to provide, around the clock caregivers in the home for a few days. But as we know, the systems don't necessarily aren't so commonsensical. So as of now, as far as I understand it, the hospice benefit per se wouldn't fly in terms of something that they would cover. And if Karen's friend, or if any of us out there happen to be lucky enough to have the resources, so one thing to do, never mind a 5-day stay, would be to ask around for home health aides, whether through agencies or through word of mouth. Home health aides can be outrageously wonderful. Godsend of a thing. So, and that, perhaps maybe not going away for a week, maybe, but maybe for a day. So having a suite of home health aides that you can call upon, or an agency that you trust. So for to take a day off or to go out, that's a beautiful idea. And to your point, you're right. The transitions, moving someone, especially in the throes of dementia, perhaps really tricky for them to change locations, and it takes days to kind of settle in. So your point is a very, very good one, Rebecca. I wish the payer world made as much sense, but meanwhile, while we try to change the systems, I would encourage anyone there, if they can afford it, to keep an eye out for home health aides that they trust to use as needed in this very way.
Great points, BJ.
And thanks, other Rebecca, for bringing this one up. It's yes, amen.
I think that's everything. Thank you so much for staying over, you two. Appreciate it.
It's a pleasure.
Best day. Great day.
It's
So
really
much
nice
to
meet
cover
you.
in this space. So much to cover.
Yes. It's big, big stuff. Well, that's a little bit of a sampling, and we'll do more together, Rebecca. It's a pleasure being with you. Thank you.
Thank you, Jeannie. Thank you, everyone. And you guys just you take it easy. I'll talk to
You too.
soon.
Happy weekend,
Okay.
everyone. Thank you.
Bye,
Bye,
guys.
everybody. Bye-bye.